All right. Good morning, everyone. Welcome back to another session of our academic subcommittee. Today's lecture is on rational use of inotrops and vasopressors and management of anaphylaxis in children. It's my great honor to introduce our esteemed resource person, Dr. Nalin Kitulwatte, the first board-certified pediatric intensivist in Sri Lanka, and the current consultant pediatric intensivist at Ridgeway Hospital. Dr. Nalin graduated from the University of Colombo in 1995 and obtained his MD in pediatrics in 2005. Had his fellowship in pediatric critical care at the Hospital for Sick Children, University of Toronto in 2009. He is the founding president of the Pediatric Intensive Care Chapter of Sri Lanka College of Pediatricians since 2019 up until now. He is a council member of Sri Lanka College of Pediatricians, the president of Pediatric Chapter for the Sri Lankan Society of Critical Care and Emergency Medicine for the years of 2012-2013. Among his many publications, both national and international, one that might be most popular among us is the Concise Handbook of Pediatric Emergencies. He is the proud co-author of the chapter on pediatric and neonatal ventilation. Anyways, I'm being very vague in all his achievements, but without further ado, let me welcome you, sir, to enlighten us on this important topic. Thank you.
Good afternoon, everybody. First of all, I would like to thank the organizers of this symposium for inviting me for this lecture. Thank you very much for that kind introduction. So today we are going to discuss about very important topic, the rational use of inotrops and vasopressors. I like to combine this with the management of anaphylaxis in children because that's part and parcel of inotrops. So first we'll discuss about inotrops and vasopressors, the rational use. So this was the inotropic pyramid that I was called into. When we were trainees, we told that if the child needs an inotrop, first we'll start dopamine. Failing that, we think about dobutamine, and that is also failing, we think about adrenaline. As a last resort, we go for noradrenaline. I know that this is completely chaotic, this is completely wrong, because this is what I want to highlight. The take-home messages, all are not similar. Inotrops and vasopressors, all are not similar. There are inodilators, there are inoconstrictors, there are pure vasopressors. Not only that, the main action is dose dependent. Good example is adrenaline. In low dose, it's a inodilator. A high dose is a inoconstrictor. So we have to select the drug and the dose depending on the disease physiology. So this is very important concept, especially in critical care. Don't forget about the big picture. Here we are discussing about blood pressure, discussing about pulse volume, discussing about the hemodynamics, but don't forget that we have a child in front of us with all the systems, not only the heart, not only blood pressure, not only blood vessels. So sometimes we forget about that we are managing a child. So don't forget about the big picture whenever you are managing a critically ill patient. So what is inotrop? So inotrop is an agent which increases or decreases the force of energy of muscular contractions. Negatively inotropic agents will weaken the force of muscular contractions. Positively inotropic agents will increase the strength of muscular contraction. So this is the physics or physiology behind inotrops. We call it cardiac function curve or Frank-Starling curve or law of the heart. You all know our cardiac output will depend on the left ventricular end diastolic volume or right atrial pressure. So when you are increasing the left ventricular end diastolic volume or right atrial pressure, initially your cardiac output increases. But however, when you reach in this level, so at a certain point of time, even though we are increasing the left ventricular end diastolic volume, your cardiac output will not increase further. Not only that, if you increase your left ventricular end diastolic volume further, the cardiac output will drop. So that is law of the heart or Frank-Starling curve. So what Inotrops does is shifting this curve to left That means for the same amount of left ventricular end-diastolic volume, now you are getting a better cardiac output. By shifting this curve to left, for the same amount of left ventricular end-diastolic volume, you are getting a better cardiac output. If you shift this curve to right, what happens is for the same left ventricular end-diastolic volume, now you are getting a lesser cardiac output. Basically, when you are decreasing the contractility, that's what happens. If you increase the heart rate, again you are shifting this curve to left. This is very important concept in pediatric critical care, because whenever you see a tachycardic child, that means there is a problem in the cardiac output. Body is trying to reverse or increase the cardiac output by increasing the heart rate. So please don't reduce heart rate arbitrarily, especially in children, because that's a compensatory mechanism. If you reduce the heart rate, your cardiac output drops, you are asking trouble. So not like in adult, please don't reduce the heart rate arbitrarily by using drugs. So if you decrease the heart rate, the converse will occur. Your cardiac output will decrease for the same amount of end-diastolic volume, left ventricular end-diastolic volume. Now you are getting a lesser cardiac output. So inotrope will increase myocardial contractility. Chronotrope will increase the heart rate. I'm introducing this word also. Lusitrope is increasing the diastolic relaxation. Now you can think, if there is a drug which causes lusitropy, that means diastole, during the diastole, the left ventricle is relaxed more blood will accumulate in the left ventricle. If you increase the inotropy, the myocardial contractility will increase, so more blood will eject from the left ventricle forcefully. And chronotrope, if you increase the heart rate, again you are increasing the volume ejected in a minute time or minute volume. So basically, if you have the drug which has three actions, lusitropic action, chronotropic action and inotropic action, you can increase the cardiac output dramatically. So inotrope will affect the contraction of the muscle. Here we are discussing about the heart muscle. So inotropic agent will increase the myocardial contractility. So these are the common inotropic drugs that we know of. On your, we can see the positively inotropic agents: digoxin, adrenaline, noradrenaline, dobutamine, dopamine, isoprenaline. On the other side, we can see the negatively inotropic agents: beta blockers, calcium channel blockers. So when you are using these drugs, remember this. So this concept is very important. Why we are using inotrope? Whenever you are having a problem in the cardiac output, your blood pressure may be low, your perfusion may be low. So because of that, you are using an inotrope. So what will happen? Benefits will be, you improve the cardiac performance, improves the contractility of the myocardium, increase the blood pressure. So that is what we are expecting. But remember, why we are using these drugs? If you think about the adult, main reason for low cardiac output is ischemia. When the patient is ischemic, heart cannot work properly, cardiac output is low. Now we are starting an inotrope to asking this poorly functioning heart to work more to increase the cardiac output. So basically, we are asking this heart to work more. To work more, the heart needs more supply, more oxygen, more energy. But the initial problem was lack of supply. So you can understand, initial problem is ischemia. Now you are asking this heart to work more. So heart needs more blood, more oxygen, more sugar. So we cannot supply. So basically, increasing heart rate causing further deterioration of the failing heart pump, increased myocardial oxygen requirement, is potentially arrhythmogenic, can increase ischemia. So don't think these drugs as miracle drugs, magic drugs. So there is a limit for that. So that is why these drugs are having problems. So that's about inotropes. So pure vasopressors, nothing to do with the heart. So here what happens is, any agent that produces vasoconstriction and rise in blood pressure. We know whenever you are having constriction in the blood vessels, blood pressure will go up. So examples are vasopressin, noradrenaline. So there are inodilators. They are inotropic action, that means you are increasing the contractility of the muscle, heart muscle. At the same time, systemic vessels are dilated. So what will happen at the end is you are increasing the flow through organs. So if you want to increase the flow through an organ, these are the drugs. So you want to increase the contractility, at the same time dilate the systemic vessels. So these are ideal drugs for to increase flow. So example, dobutamine, milrinone. But remember, what will happen to the blood pressure? Since you are dilating the blood vessels, your blood pressure will go down. So don't worry about the blood pressure. If you are using these drugs, it will anyway go down, but you are increasing the flow through organs. In contrast, inoconstrictors, inotropic drugs with vasoconstriction properties. Now you can imagine they will increase the blood pressure because heart is working more forcefully. At the same time, you are constricting the vessels, so blood pressure will go up. So here we can increase the perfusion pressure. So if you are worried about the perfusion pressure, these are the drugs: dopamine, adrenaline, noradrenaline. These are the drugs to increase perfusion pressure. So now we come to very important aspect of discussion about these drugs. So without knowing these receptors, you cannot go beyond. So we have beta 1 and beta 2 receptors, alpha 1 and alpha 2 receptors, DA1 and DA2 receptors. They are adrenergic receptors. At the same time, we have V1 and V2 receptors. They are vasopressin receptors. So briefly, if I go through this drug, the action of these receptors, if you increase the alpha 1 agonist, alpha receptor agonist, ultimately you are causing vasoconstriction. I'm not going to discuss about the middle part. So alpha 1 agonist stimulation will constrict your vessels. So alpha 1 receptors causes smooth muscle contraction. Main action is vasoconstriction. There are other actions also, but today our interest is about vasoconstriction. Alpha 2 receptors causes vasodilatation. There are so many other actions also, but remember vasodilatation. So in contrast, beta agonists, beta stimulators have three main actions: positively chronotropic, heart rate will go up; positively inotropic, your cardiac contractility will increase; and some of these drugs will cause vasodilatation. So beta 1 receptors, positively chronotropic, heart rate will go up; positively inotropic, cardiac contractility will increase, and at the end, increase ejection fraction. Beta 2, smooth muscle relaxation is a main action. So it can dilate the arteries. So if you are using a beta 2 receptor agonist. So in summary, beta 1 increase rate and force of cardiac contraction. Beta 2 causes vasodilatation in skeletal muscle. So we come to the dopamine receptors that will increase renal and coronary blood flow and causes arterial vasodilatation. Because of this, about 10 years ago, when we were trainees, there's a concept of renal dose of dopamine. We believe that if you are starting a small dose of dopamine, we can increase the perfusion through the kidney. But that concept is no longer valid. Nobody is believing on that. So in summary, this is what happens. Beta 1 stimulation causes inotropic and chronotropic action. That means your cardiac contractility will go up and heart rate will go up. And beta 2 stimulation causes vasodilatation. Alpha 1 causes vasoconstriction. Alpha 2 causes vasodilatation. DA1, DA2, these are dopaminergic agonists, causes diuresis, natriuresis, and vasodilatation. V1 causes vasoconstriction. V2 is an antidiuretic effect. These are not adrenergic receptors. V1 and V2 are vasopressin receptors. So if you go to the drugs, this is what happens. Dopamine will act on beta 1, beta 2, alpha 1, DA1, DA2. Dobutamine, beta 1, beta 2, minimum alpha 1. If you go through these drugs, so what will happen? Dopamine will act on beta 1. Beta 1 will cause inotropic and chronotropic action. We act on beta 2, causes vasodilatation. Alpha 1 causes vasoconstriction. Now, if you remember these, there's a confusion. So dopamine will act on beta 2, causing vasodilatation. The same drug will act on alpha 1, causing vasoconstriction. Whenever there is a confusion like this, it's very simple. Low dose always stimulates the beta. High dose always stimulates the alpha. So high dose dopamine stimulates the alpha 1 receptors, causes vasoconstriction. Low dose dopamine causes vasodilatation through the stimulation of beta 2 receptors. Dobutamine, beta 1, inotropic and chronotropic action, beta 2, vasodilatation. Here, minimum alpha 1, that means vasoconstriction is minimum. That is why dobutamine is a inodilator. Look at this, adrenaline, epinephrine, will act on beta 1, inotropic and chronotropic action, beta 2, vasodilatation, alpha 1, vasoconstriction. Same confusion. So again, low dose adrenaline is a vasodilator through beta 2 agonist. High dose adrenaline is a vasoconstrictor through alpha 1 stimulation. Noradrenaline, alpha 1 vasoconstriction, beta 1 inotropic and chronotropic, minimum beta 2. That means vasodilatation is minimum here. So that is why noradrenaline is a inoconstrictor. Vasopressin, the action is different, V1 and V2. Milrinone is a completely different drug. In a minute, we'll discuss on that. The same thing. Now you can see dopamine will act on alpha 1, beta 1, beta 2, DA1 and DA2. So that means all the receptors are stimulated depending on the dose. High dose, inoconstrictor, low dose, inodilator. So dobutamine, only 1 plus for alpha 1. That means vasoconstriction is minimum. So that is why it is a inodilator. Noradrenaline, only 2 pluses for beta 2. That means minimum vasodilatation. So that is why it's a inoconstrictor. Adrenaline will act on all 3 receptors. So again, high dose alpha, low dose beta. So high dose vasoconstriction, low dose vasodilatation. Now look at this, isoprotenolone. So no alpha agonist action at all. So it's a pure beta agonist. So action is only on beta 1 and beta 2 receptors. So no alpha, no vasoconstriction. In contrast to this phenylephrine, so no beta at all. So only action is on alpha receptor. So it's a pure alpha receptor agonist. So some of these drugs, isoprotenolone and phenylephrine is being used in cardiac ICUs. So if you go one by one, dopamine is a metabolic precursor of noradrenaline and adrenaline receptors. Already we have discussed DA1, DA2, beta 1, beta 2 and alpha. So in low infusion rate like 1 to 5 mics per kg per minute causes vasodilatation. We have discussed already. So intermediate dosing 5 to 10 mics per kg per minute, chronotropic and inotropic. So that will increase the systolic blood pressure. Minimum change in diastolic pressure, increase the pulse pressure. High dose 10 to 20 mics per kg per minute, where we are aiming at alpha receptors, alpha effect, increased vascular resistance causes vasoconstriction, and you are increasing the systemic vascular resistance as well as pulmonary vascular resistance, you are increasing the blood pressure. Dobutamine will act on beta 1 and beta 2 receptors. Beta 1 action will increase cyclic AMP, increase serum calcium release, and increase contractility. So beta 2 causes peripheral vasodilatation and decrease in systemic vascular resistance. So again, remember, so we discussed about this previously also. If you think about the heart failure, this is an ideal drug because what we want in heart failure is to increase the contractility of the heart. At the same time, if I can dilate the peripheral vessels, heart will find it easier to pump out blood. So that's the ideal drug to use in heart failure. But unfortunately, it can cause increase in myocardial oxygen consumption. So as I mentioned earlier, main reason for heart failure in adult is ischemia. So now we are asking this heart to work more. So heart needs more energy, more supply, more oxygen, more glucose. So if you are increasing the myocardial oxygen consumption by these drugs, so myocardium, the body cannot supply this oxygen. So that's a problem for the heart. So that is why it can cause tachycardia, it can cause dysrhythmia. It is associated with increased mortality in adult heart failure patients. The routine use of dobutamine for heart failure has fallen out of favor now because we have better drugs. So dobutamine in summary is inotrope, chronotrope, vasodilator, but remember it increases the myocardial oxygen consumption. So that's why it's not a very good drug. Coming to adrenaline, so as we discussed earlier, that will act on beta 1, beta 2 and alpha 1 receptors in low dose. main action is on beta 1 and beta 2. So low dose means 0.01 to 0.1 mics per kg per minute. So up to 0.1 mics per kg per minute is beta stimulation. That will increase the heart rate and inotropy. Stimulation of beta 2 receptors promote relaxation of resistance arterioles, promoting decreasing systemic vascular resistance and diastolic blood pressure. So blood pressure can go down with these drugs, these doses, but inotropic action will increase. In higher dose, that means more than 0.1 mics per kg per minute, we are aiming at alpha receptors, mainly the alpha 1 receptors, causes vasoconstriction. So there you can increase the systemic vascular resistance. By that we can increase the blood pressure. So noradrenaline will mainly act on alpha 1 and beta 1. Minimum beta 2 already we have discussed. So elevation of systemic vascular resistance. Here beta 1 action will increase the cardiac contractility. Alpha 1 action will increase the vasoconstriction. So blood pressure can go up. But remember this, peripheral vascular resistance will increase in kidney, liver, skeletal muscles, mesenteric vessels. Coronary blood flow increases due to direct coronary dilatation and increase in blood pressure. Why we are measuring why we are maintaining blood pressure? That is to maintain perfusion pressure, that is to maintain vital organ perfusion. So whenever you think about blood pressure, we think by increasing blood pressure, I can increase the vital organ perfusion. But if I increase the blood pressure with vasoconstriction, what will happen? With vasoconstriction, blood pressure is going up, but the perfusion will reduce. Can we maintain perfusion by increased blood pressure by using vasoconstrictors? No. Remember, by increasing vasoconstriction, you can increase blood pressure, your numbers will be good, monitoring chart will be good, but the patient is not getting good perfusion. Coming to vasopressin, so that's the exogenous parenteral form of antidiuretic hormone produced by supraaortic and the paraventricular nuclei of the hypothalamus. It is stored and released by this posterior pituitary gland in response to increase in plasma osmolality or as a baroreflex response to decrease in blood pressure and blood volume. So vasopressin action will have two receptors, V1 and V2 receptors. So action on V1 causes significant vasoconstriction. So vascular smooth muscle in the skin, skeletal muscle, fat, pancreas, thyroid gland, GIT, coronary vessels, brain, everywhere vasoconstriction is a massive action. So again the same concept, you can increase the blood pressure, but what will happen to the perfusion? So perfusion will be reduced through vital organs. So that is not a good thing. So there is a very good study done about 10 years back. It's called VIP, Vasopressin in Pediatrics. The summary was, if you start vasopressin in pediatric patient, outcome is very poor. So that means child is going to die if you are starting vasopressin. That's the summary of that research paper. That may be two reasons. Usually we are starting vasopressin as a last resort. So anyway, child is going to die, we are starting vasopressin and now blaming vasopressin for the death. That may be the cause. Or else, vasopressin causing vasoconstriction, perfusion to the vital organ is less, reduced, so that is the cause for death. So anyway, if you are going to start vasopressin, you have to remember outcome may be very poor. To summarize this is nothing to do with inotropy, but since we are discussing vasopressin, I think this is also important. V2 receptors will increase the water permeability in the collecting duct. That is why we are using these drugs in diabetes insipidus. Increased circulating concentration of procoagulant factors 8 and 1 milligram factor. Vasoconstriction of the mesenteric vasculature. That is why we are using this drug in upper GI bleeding. So again, just remember, so action on V2 receptors is needed to treat diabetes insipidus. So we have a specific drug for V2 receptor stimulation, that is called desmopressin, that is called DDAVP. So when you are having a specific drug, it is not rational to use the non-specific drug to treat diabetes insipidus. So basically what I am trying to say is, please don't use vasopressin in diabetes insipidus, because vasopressin will cause vasoconstriction that is not necessary in diabetes insipidus. It is like using Adrenaline in asthma. When we were HOs, we were using adrenaline. Subcut adrenaline is a standard therapy for asthma. Now we have a specific beta-2 receptor agonist, salbutamol. So when you are having a specific drug, we never use non-specific drug. Same applies to the vasopressin also. Please don't use vasopressin in diabetes insipidus. So now is emerging vasopressin in cardiac arrest. So in small letters in pediatric protocols, we are using cardiac arrest protocols, we are using vasopressin instead of adrenaline. Refractory hypotension in septic shock, recommended by the American Heart Association as an alternative to epinephrine in adult patient with ventricular fibrillation. Vasopressin must be administered parenterally because it's degraded by the gastrointestinal tract. So previously also you have seen this slide. Inotropic action will increase myocardial contractility. Chronotropic action will increase heart rate. Lusotropic action will increase diastolic relaxation. If you think about the heart failure, if I can dilate the left ventricle during diastole, more blood will accumulate in the left ventricle. If I can increase the heart rate, more blood will eject to the systemic vessels. If I can increase the contractility, more blood will eject because of the increased myocardial contractility. So this is the ideal drug in heart failure. So this is it, milrinone. Now we have this is a prototype. We have other drugs also. It's a phosphodiesterase inhibitor. It has inotropic action, lusotropic action, vasodilator. So you can't ask more. So usually phosphodiesterase inhibitors increase cardiac muscle contraction, increase vascular smooth muscle relaxation, increase cardiac output, and look at this, without increasing myocardial oxygen consumption or ventricular afterload. That's the most important part. If you are comparing milrinone versus dobutamine causes increase in myocardial oxygen consumption, basically increase in the ischemia. But milrinone will not do that. That's why it's a superior drug. Whenever you have milrinone, please use it, not dobutamine. So this is what I think, vasopressors and inotropes, everything you need to know. So I have just created this. So we are worried about blood pressure, we are worried about cardiac output. Only four columns will be there. So your blood pressure may be normal, but your cardiac output will be low. So your blood pressure may be low, your cardiac output will be low. Your blood pressure may be normal, the low, but the cardiac output will be low. And both will be normal. So just remember, so whenever you are facing a child or the adult, whatever the patient, with some problem, what you need is clinical examination. You have to find which box this patient belongs to. Whether this patient's blood pressure and cardiac output both are low, whether this patient's cardiac output is only the lowering factor, blood pressure is normal, whether this patient is having low blood pressure but good cardiac output. So if both are normal, if blood pressure is normal, cardiac output is normal, don't do anything. That's very simple. If your blood pressure is normal but cardiac output is low, you have to increase the cardiac output. If your blood pressure is low but the cardiac output is normal, you have to increase the blood pressure. If both are low, you have to increase both. So by clinical examination, you have to find which box this patient belongs to. By doing that, your job will be very simple. Then you can select the drug. So if the both are normal, you don't have to give anything. If the blood pressure is normal but the cardiac output is low, you can think about this type of drug. If the blood pressure is normal but the cardiac output is low, you can think about dobutamine and milrinone. If both are low, you have to use true drugs. So usually we are using adrenaline and dobutamine or noradrenaline and dobutamine, that type of drug. So that will be very simple once you examine the child. Little bit about adrenaline in cardiac arrest, because there are so many misconceptions. Usually we are using 0.1 ml per kilo in 1 in 10,000 adrenaline. So that is 10 mics per kilo. So here we are using a very high dose. Basically we are stimulating the alpha receptors. So everywhere we are trying to constrict the systemic vessels and try to send some blood towards the heart. you are doing the cardiac massage, you are doing the cardiac contraction. At the same time, peripheral blood will be diverted to the heart by using vasoconstrictor action of adrenaline. So now we can think about specific diseases. Now we have discussed about the inotrope and vasopressors. So anaphylaxis, in a minute we are going to discuss. Anaphylaxis, main problem is massive vasodilatation. So we have to use a vasoconstrictor. So no point stimulating beta 2 receptors here. We want to stimulate alpha 1 receptor. So we need alpha 1 receptor agonist. So don't use dobutamine in anaphylaxis. Cold shock, peripheries are cold. Why peripheries are cold? Whenever you are having a low perfusion, what our body does is, body will constrict the peripheral vessels to send some blood towards the vital organs. That's why peripheries are constricted, peripheral vessels are constricted. Because of that, peripheries are cold. So treatment of this type of shock is fluid. Please don't try to dilate these blood vessels, because this is a compensatory mechanism to maintain the vital organs. If you go against that and dilate the peripheral vessels by using dobutamine or low dose adrenaline, you can kill the child very easily. So please don't do that. That's why we are not using inotropes in dengue. Dengue peripheries are cold because of the low volume, because of the vasoconstriction. Body is trying to send some blood towards the vital organs. Please don't try to dilate these vessels. In warm shock, what happens is massive vasodilatation, like anaphylaxis, like in septic shock. The main problem is vasodilatation. So there the treatment should be vasoconstriction. That's why in warm shock we have to use a vasoconstrictor, but in cold shock you should not use a vasodilator. In heart failure, already we have discussed, we want to increase the cardiac contractility, we want to dilate the peripheral vessels, and you want to dilate the left ventricle during diastole. So ideal drug is milrinone. So what will happen in right to left shunt, like in Eisenmenger syndrome? So the main problem is here. Now right side blood will go to the left side through this VSD. So we want to reverse this. You want to reverse this shunt if you want to survive. So problem is here. Please dilate the pulmonary vessels by using pulmonary vasodilators like oxygen, like nitric oxide, that type of drug, and you can give more fluid. You need to constrict the systemic vessels. So there you have to use a alpha receptor agonist. So ideally we should use a vasopressor like high dose adrenaline, vasopressin, noradrenaline, that type of drug. Raise ICP. So whenever you are managing meningitis, encephalitis, traumatic brain injury, diabetic ketoacidosis with raise ICP, this is the concept. Main aim of the management of these children is maintaining the adequate cerebral perfusion pressure. So this is my common cartoon for that. So we want to perfuse this organ. So perfusion pressure of the brain will depend on the mean arterial pressure and the intracranial pressure. When you are having high intracranial pressure, CPP will reduce. When you are having high mean arterial pressure, CPP will increase. So here what we want, you want to reduce the ICP, we want to increase the mean arterial pressure. So here we can use to increase CPP, you have to increase the mean arterial pressure. So you can give volume, you can give inotropes, you can give vasopressors. To decrease intracranial pressure, you can use hypertonic saline, that is 3% saline. You can use mannitol, you can use external ventricular drainage. At the end, you can do a craniectomy. So basically, you have to use inoconstrictors. Again, please don't use dobutamine or low dose adrenaline in this type of patients. Now we coming to the very important topic, that is about the management of anaphylaxis in children. This is based on Resuscitation Council UK. Most recent guidelines is published in 2021 May. Emergency treatment of anaphylaxis. So anaphylaxis is a clinical diagnosis. It has a sudden onset, rapid progression, problem in airway, breathing, circulation. Skin mucosal changes alone is not anaphylaxis. Please don't overdiagnose this anaphylaxis, because that is also common. So if you think about the spectrum of allergy, this is what happens. You can see sometimes mild localized skin symptoms and swelling of lip face, generalized skin reaction, and later we can have airway, breathing, circulation problems plus or minus skin symptoms. Here, no airway, breathing, circulation problems, not anaphylaxis. So after this point, airway, breathing, circulation problems, that is anaphylaxis and severe anaphylaxis. So it's basically skin allergy plus ABC problem. So these are the problems that we are expecting to see. Airway problems, airway swelling can cause throat and tongue swelling, causing difficulty in breathing, swallowing. Patient may feel their throat is closing, hoarse voice, stridor, high-pitched invasive noise caused by upper airway obstruction, breathing problems, increased work of breathing, bronchospasm. Patient become tired with the effort of breathing. You can see hypoxemia, saturation may be less than 94. Respiratory arrest also can happen. And circulatory problems, signs of shock, pale clammy extremities, significant tachycardia, hypotension, dizziness, decreased level of consciousness, arrhythmia, cardiac arrest can occur. So you need to have airway, breathing, circulation problems to diagnose anaphylaxis. So then management is very simple. Only 4 things to be done: positioning, airway management, adrenaline, aggressive fluid resuscitation. Now think about even a very small hospital in Sri Lanka, we can do all these 4 things. You can position the child, you can manage the airway, you can find an ambu bag if necessary, adrenaline is available, normal saline is available. That's why I'm always telling no child or no patient should die of anaphylaxis in Sri Lanka. But unfortunately, that is happening. So little bit elaborating of patient positioning. So must not walk or stand during acute reaction. Fatality can occur within minutes if a patient stands, walks or sits up suddenly. If you go through the recent problems that we face, patients are dying with anaphylaxis. They are trying to walk, they are trying to run, they are trying to go to the toilet. So that should not happen. That is the main problem with anaphylaxis death. Patient with airway and breathing problems may prefer to be in semi-recumbent position. This will make breathing easier. And lying flat with or without leg elevation is helpful to patient with low blood pressure, circulation problem. So please, no upright position, other 2 are acceptable. So that is a key. So this simply we can do in any hospital in Sri Lanka. Airway management, if you have stridor, treatment is IM adrenaline. You can use nebulized adrenaline. We should repeat it. If the child is having wheezing, nebulized adrenaline, salbutamol, aminophylline infusion. At the end, intubation and ventilation. IM adrenaline give as soon as possible. I have told you not to overdiagnose anaphylaxis. Having said that, even if you give 1 dose of adrenaline without anaphylaxis, nothing will happen. So don't worry about giving adrenaline unnecessarily. You can save child sometimes. So IM adrenaline is a first line treatment for anaphylaxis in all healthcare setting. Why IM? It is safer than IV. It does not require IV access. The IM route is easier to learn. So this is also important. Repeat the IM adrenaline dose after 5 minutes if there's no improvement in the patient's condition. This is what we are lacking. We are so worried about adrenaline. Even with anaphylaxis, we are not giving repeated adrenaline doses because in Sri Lanka, we are more worried about the side effects than effects of the drug. We know about side effects than effects. So we are so worried about side effects, thinking that we are not giving repeated adrenaline doses. But please don't do that. Not like previously, the most recent guidelines, the adrenaline dose has simplified. Now you can see adrenaline dose is 1 in 1000. Adult and child above 12 years, it should be 0.5 ml to 1 ml. 6 to 12 years, 0.3 ml. 6 months to 6 years, 0.15 ml. Below 6 months, 0.1 to 0.15 ml. Please take this as a poster or something to prepare this poster and paste in wherever you are practicing. So this is very simple. Just draw the adrenaline and give the dose. Less than 6 months, 0.1 to 0.15. This is not per kg. 6 months to 6 years, 0.15 ml. 6 to 12 years, 0.3 ml. Adult and children after 12 years is 0.5. You can give even 1 ml. So I have put it again because just to highlight, it's very simple now. Above 12 years, 0.5 ml, 6 to 12 years, 0.3 ml, 6 months to 6 years, 0.15 ml, below 6 months, 0.1 to 0.15 ml. So and where to inject? Again, don't use other places. Inject at anterolateral aspect of the middle third of the thigh. Anterolateral aspect, middle third of the child, where it can absorb very quickly. So that's the place of preference now. So what they say is give IM adrenaline every 5 minutes until adrenal infusion is started. So this is what I want to mention. So intravenous adrenaline for anaphylaxis to be given only by experienced specialists in an appropriate setting. So in a minute I am going to discuss how to use IV adrenaline, but if you are not familiar, please stick to IM adrenaline. That can save your life. So intravenous adrenaline for anaphylaxis to be given only by experienced specialists in an appropriate setting. This is the 2021 guidelines. So antihistamines not recommended as part of the initial emergency treatment of anaphylaxis. Steroid not recommended. Circulation, adrenaline IM can be given every 5 minutes. I am highlighting this. Please give IM adrenaline every 5 minutes if the child is not improving. Fluid boluses, guideline says 10 to 20 ml per kg normal saline can be repeated. What we prefer is to give 20 ml per kilo. Don't worry about fluid when you are having massive vasodilatation. And adrenaline infusion, in a minute I am going to discuss. So anaphylaxis management, again I am highlighting 4 things to be done: positioning, airway, adrenaline, normal saline. No child should die with anaphylaxis in Sri Lanka. So anaphylaxis, airway, breathing, circulation, disability, reassess, but don't hesitate to repeat adrenaline if needed. So I'm summarizing the guidelines in 2021 guidelines. So we have to diagnose anaphylaxis, look for sudden onset of airway and breathing and or circulation problems, plus or minus skin changes. You need to have ABC problem. So then patient positioning, we have already discussed, that is very important. No upright position, that's the killer. Then IM adrenaline, we have again and again we are telling this. So less than 6 months, 0.1 to 0.15 ml, 6 months to 6 years, 0.15 ml, 6 to 12 years, 0.3 ml, adult and above 12 years, 0.5 ml. So we have to give anterolateral aspect of the middle third of the thigh. So repeat IM adrenaline after 5 minutes if there is no improvement. That is again very important. After 5 minutes, if the child is not improving, please give the second dose. So even after second dose, if there is no improvement, we call it as a refractory anaphylaxis. There, you have to establish a dedicated peripheral IV or IO access. Up to this level, even without IV access, we can manage. So refractory anaphylaxis, you have to give rapid IV fluid bolus, is 0.9% normal saline, bolus is 20 ml per kilo. You can start adrenaline infusion. So because adrenaline is essential for treating all aspects of anaphylaxis. So here, this is also important. I'm highlighting again, give IM adrenaline every 5 minutes until adrenaline infusion has been started. Again, same guidelines, what they are saying is, if you are not familiar, forget about this IV business and every 5 minutes give IM adrenaline. That can save a child very well. So peripheral low dose IV adrenaline, this is the dose. What they say is 1 milligram, that is 1 ml of 1 in 1000 adrenaline in 100 ml of normal saline. 1 ml in 100 ml of normal saline. In both adults and children, start at 0.5 to 1 ml per kg per hour. If the child is 10 kilos, we have to give 10 ml. This is a low dose peripheral adrenaline infusion after 2 doses of IM adrenaline if you are familiar using IV adrenaline. So this is the guidelines. Anybody can download this. This is Resuscitation Council UK 2021 guidelines. This is the initial management. This is the refractory anaphylaxis. I am taking this from the summary is taken from this point. So this is one of the success stories. I am always telling this when I am delivering this lecture with the permission of this very famous neonatologist. At that time, this girl was 11 years, one of the consultant pediatrician's daughter, very famous if I may mention the name, presented to us to LRH with severe anaphylactic shock. She was allergic to cow's milk. The saturation was 30, unrecordable blood pressure. Now look at this. This child needs 35 ml per kilo fluid, that is normal saline, and 15 doses of IM adrenaline. This is LRH ETU and LRH ICU. We could have easily put a central line and start adrenaline infusion, but we stick to the basics. Continuous nebulization with adrenaline and salbutamol, intubation and ventilation for 8 hours, but she went back to school in 3 days. This is her with my sister at that time. So with permission of the father, I'm publishing this because now whenever I see this type of success story, you remember it more effectively. So take home messages, inotropes, all are not similar. There are inodilators, there are inoconstrictors, there are pure vasopressors. Not only that, main action is dose dependent. A good example is adrenaline, already we have discussed. Low dose adrenaline is an inodilator, high dose adrenaline is an inoconstrictor. So you have to select the drug and the dose depending on the disease physiology. In conclusion, make the hemodynamic diagnosis. No point telling me this is a septic shock, this is anaphylactic shock, this is dengue shock. So hemodynamic, what we want to know is what happens to the vessels, whether it's a cold shock, whether it's a warm shock, and optimum preload. Whatever the diagnosis, you need some fluid. Without giving fluid, no point starting inotropes. And maintain perfusion pressure and flow. Both are important. No point having perfusion pressure without flow. No point having flow without pressure. And this is also important. Very, very close monitoring, because this time the child may be having vasoconstriction. Within few minutes, child's vessels may be dilated. So very, very close monitoring is important. You cannot just prescribe in the morning and come and see next day morning. So this is my golden rule in critical care. Sufficient is enough. So you have to satisfy with sufficient things. Better is the enemy of good. Don't try to do better things. Sufficient is enough. So aim at sufficient blood pressure, aim at sufficient cardiac output, but don't aim at better blood pressure or better cardiac output. Then your outcome will be better. And this is also important. I have mentioned initially also, don't forget about the big picture. So far we have discussed about the heart. So far we have discussed about the vessels. So we forget this child is having a kidney, brain, liver, mesenteric vessels. All these are important. So please don't forget about the big picture when you are managing a critically ill child. Thank you very much.
So we are having some questions. The first question is, what is the dose of dopamine dose that can be sent via the peripheral line?
Yes, very good question. Actually, we were thinking about this earlier, but now what they say is now any drug, dobutamine and dopamine, very safely given as through a peripheral line. So you don't have to worry about the central line. But adrenaline and noradrenaline in high dose, above 0.1, you need central line. But below that, again, you can start with peripheral line. Again, I have to highlight, so even without a central line, you have to start these drugs, because if the child is going to die, you should not do that because of fear. So you can start safely these drugs in peripheral line. So safely, because adrenaline and noradrenaline is the main problem. Dobutamine and dopamine, we can safely use peripheral line also.
Thank you so much, sir, for that informative lecture. Definitely you have improved our confidence in following through with the guidelines and do the needful. We hope to have you again with such important topics to widen our horizons, and thank you very much again, sir.